innovation and how we need to remove obstacles to really allow those green shoots of innovation to occur. We need to be constantly, vigilantly looking for those opportunities to let innovators, physicians, patients work free of some other controlling entity, even a controlling entity that says they're in their best interest, right? Let people be able to decide themselves. Because I think you guys are of a generation where you're really hearing that to be a paternalistic physician is bad. But what we've done now is outsource that paternalism to the government. And the government now is becoming the paternalistic force in medicine. Dr. Graboyes has, the other thing you should check out from him is he has online, if you Google Fortress and Frontier, what I love about your work is that you try to make it, let's get away from Republican, Democrat, conservative, liberal. Let's look at what is really those values that we all share in common, and what's preventing us from reaching that very common goal of getting as much health care to as many people in as high a quality at an affordable price, so as many people as possible are accessing this independently. And that's what the Fortress and Frontier is really all about. How do we release so he also, he through the Mercatus Center sponsored a series of dinners where they ask medical innovators to come together. What kind of policies do we need in place to really empower innovators to be able to make that entrepreneurial spirit available to the general American public? And I think you're right. I think we're going to learn a lot from other countries who don't have the impediments that we do. But read the Fortress and Frontier. That's great. And you've written a lot about Enable and stuff. So he's a great resource if you want to talk about the power that we have of really reaching people with high quality, low cost healthcare and not having to rely on other people to provide it. We want to empower people to achieve as much as they can underneath their own ability. So thank you for coming here.
Plus, I'm fairly fun. So here are the things everyone knows. So every single discussion of healthcare in America starts with these things, which everyone agrees to. American healthcare spending is excessive and unsustainable. American healthcare outcomes are inferior to those of other developed countries. We know from opinion polls that people in other developed countries are happier with their healthcare than we are with ours. Health of a nation's population depends primarily on the quality of its healthcare. And on and on and on. I'll let you read them. Being uninsured has a large negative impact on health. The uninsured are real expensive. Healthcare bills cause bankruptcy. Malpractice really wrecks everything. Profits eat away and make it too expensive. Medicare and other public programs have lower administrative costs than for-profit insurers. Healthcare differs from industries in that a large percentage of decisions involve life and death decisions, and competition doesn't work in healthcare as it does in other industries because the issues are too complex for untrained laypeople. Now, everyone agrees on these things. Democrats agree on it, the Republicans agree on it, everyone, and these are the points on which all discussion of healthcare in Washington and in the state capitals begin. And, in my view, every bloody one of them is wrong. Every single thing is wrong. Wrong, let's say it. Wrong, wrong, wrong. So, a large part of what I'm going to be doing in the next year or two as we revamp our program, Mercatus, is going to be focusing on these things because these screw up every conversation that you will ever have in healthcare. And they're relatively easy to debunk if you really look into the data, but no one does. And it tends to be one side saying, because of this, we need the government to take over everything. And the other side tends to answer, well, I agree with all that, but the government still shouldn't take over everything. And it's a losing proposition to argue about that. Beth was attending another debate in town last night. This was the whole thing about the debate. I don't know how many were there. Anyway, let's get on. These are the things that barely matter, that I do not care about. This, I am adopting the pose of nihilist Bob. What do you think of Obamacare? I don't care. Is it a good thing or bad thing? I don't care. It didn't do much. How about if we were to repeal and replace? I don't care. Medicaid expansion? Do it. I don't care. Do it if you want. Move to a single payer? Won't do anything, so I don't care. Do it if you want. And universal coverage, I don't know. Well, it doesn't actually matter. I really, honestly believe we've had a 75-year debate over coverage that the more I think about it, the more I look into it, I don't care. It doesn't matter. It doesn't really change things. Now and again, a lot of the debates start on some debate over what is the appropriate sort of coverage. Now, I don't like the ACA. Never did like it. I spent many years of my work opposing it, and it's a bad law, but what came before it was bad. The things that are proposed to replace it by the right and by the left are bad. It's focusing on the wrong issues, which is where this talk is ultimately going to go. I wrote a piece a couple months ago in the National Review where I said, you want to go to single payer? I don't care. Why? Because we're already there. 50% of Americans are already on public insurance, health insurance. They're already on single payer. 50% of the population, they're on Medicare or Medicaid or the VA or whatever else. They're already there. And what about the rest of us? Well, we've got something to preserve, right? Well, so I've got a Blue Cross plan that Mercatus provides me with. And guess what? It looks just like a Medicare plan. You know why? Because there's one guy at Blue Cross who's sitting here administering my plan, and there's one in the cubicle right next to him who's administering Medicare. The Blues and all the other commercial insurers say, well, a huge part of our business is Medicare plans, so why don't we design all of our commercial plans to look just like Medicare plans? And that's where we've been for decades and decades and decades. And so what you've got is a single-payer system with a bunch of rooms. You got a Medicare room, a Medicaid room, an employer-sponsored room, whatever. And the whole debate over the Affordable Care Act and all that was dealing with the little odd piece that was left out, the individual market and the uninsured, whatever. Those are the people in the unfinished basement of the insurance building that we have in this country. If the people who want single payer were to win tomorrow and we were to go to it, my expectation is you'd have a bunch of shuffling of the chairs around the deck, but ultimately you wouldn't have a whole lot of change. What you would have, why? Because we're already just about there and have been for a long time. The restrictions that most of the people in this room and I fear about that sort of a system are already in place in one way or another. And that's where I spend most of my time talking. So let's go on a little bit. Things that do matter. So this is something I've been talking about. Let me explain a little. This explains the previous slide. This is my calendar test. And by the way, Charlotte and Beth, you let me know if I'm running, how my time runs.
Okay.
Maybe signal me when I'm at 15 minutes, 30 minutes, and 45, so I'll know not to talk too much. So, picture, if you would, a doctor who works 10 hours a day. 5 hours is doing administration, reading journals, reading charts. 5 hours is seeing 20 patients at 15 minutes apiece. Somebody goes out on the street and hands out 4 gift coupons, good for 1 visit to that doctor that day. What can the doctor do? Doctor can work longer hours. Doctor can shorten all those visits to 12 and a half minutes apiece, remembering that an awful lot of that's already devoted to filling out EHRs and other things government's already saying to do. Or you can cut out 4 appointments and say, I can't see you, I got to see these guys with the gift coupons. Now, I do this every day, for every doctor, for every hospital, whatever. And that's basically what our whole debate is about. So in 2010, they passed Obamacare, and what did it do? We already had a whole bunch of doctors in hospital beds, and we had a whole bunch of lab equipment and therapists and nurses and whatever. Obamacare didn't change much of any of that. And guess what? All those people and all those resources were pretty busy before 2010. So now it's, look, all these uninsured people now have coverage. So they're seeing doctors more frequently, which means if you didn't create any more doctors or any more time for them, and these guys are seeing more of the doctors, what does that mean? Come on. They have some math in med schools. If these people are seeing more of those doctors, what's happening over here? We're seeing less. Somebody, and we're seeing it in lots of ways. People have much higher deductibles, people have much higher copays, their networks are narrowed, and so some people, there's no doubt the ACA helped some people, it hurt some other people. It's probably easier to take a TV camera and show the people it helped and say, see all the good things happening? And than it is to go around the country and say, well, this guy, he would have been seeing his doctor, but he's not now because it's too expensive and can't get an appointment, et cetera, et cetera. So the ACA was mainly a redistributive action. Also, it said, these guys are going to pay more, and these guys will pay less. Now, when the various repeal and replace proposals came out, I wasn't overly thrilled with most of those because essentially they were going to do the same thing. It was going to try to crank back a bit, but still it wasn't really fundamentally changing the amount of resources available, nor how we use those resources. The same algorithms that determine how many doctors and nurses and sutures and whatever is required for a surgery changed very little because of any of these. And if you really want to get to the goal, what I think should be the goal of healthcare reform and policy, it is to get better health, and I don't say healthcare, better health for more people at lower cost year after year. You have to either ramp up the resources, which is going to increase costs. I have students, I teach in a couple of medical centers, and my students are mid-career doctors and nurses. They say, how can we get costs down in this country? And I say, first of all, you're aware, aren't you, that you're the cost? And that kind of hits them in the face like a fish. I didn't think, never thought of that one.
Hit in the face with a fish.
Yep. And, or you change the way we actually deliver care and produce health. And we do that really. My calendar test is asking whether a change relieves that doctor's calendar so they don't have to work longer hours or shorten their visits or cut out prior appointments. And there are basically three ways you can do it, and this is an oversimplification, but it's a way I find useful to think about it. You can either shift some of the care to non-physician providers, sort of downshift from getting a doctor to do it to getting a nurse practitioner or a pharmacist or a nurse anesthetist or a physician assistant to do it. Or you shift some of the burden to intelligent machines, because for the first time in history, we have machines, and I'll show you one of them, and we'll talk about more of them, that can actually do some of the care that used to require a doctor. Or you shift some of the care to the patient, him or herself. So let's talk about some of those things. So I wanted to give myself a clever title, so I did the Falcon Heavy thing. Everyone know what Falcon Heavy is? That's the big rocket that went up. Elon Musk put it up. It's a private entrepreneur. There's a lot of government money, so it's not this is not the libertarian's dream scenario. But it really is a sea change from the old NASA's going to do everything model. Now, I'd like to point out here, I wrote an article a couple years ago with Dr. Tom Stossel, a cancer researcher at Harvard. You may know his brother, John Stossel, who's a TV commentator. And the Obama administration announced that their cancer moonshot program, they were going to devote $1 billion to conquer cancer. And I don't want to ridicule it. You know, Joe Biden lost his son to cancer. I know it was a sincere effort. But $1 billion is less than what it takes to get a new variety of aspirin through the FDA. It is a pittance. It is nothing. And I said, and so Tom and I wrote this article saying, curing cancer is not a moonshot. And my argument is that, and I'm not a Puritan in these things. Government has its role in innovation. But I said where government is especially good are places where the science is already clear and known, and you really just have an engineering problem of how to do it cost effectively. And secondly, it's got to be something where you have a very clear criterion before and after. Here's what we're trying to do. And afterwards it's, yes, we did land a guy on the moon and brought him back safely. Yep, check the box. And third, you don't really care very much about how much it costs. And there are a number of things the government's done that are appropriate in that. So I like to name the development of the atomic bomb, landing on the moon, the Human Genome Project, though that was a sort of a hybrid thing, the development of DARPA's development of the original internet, or the elimination of smallpox. I'm okay with, government had a big role in these. They did very well. They got it out of the way. 2 weeks ago, I was at Hoover Dam. They did a pretty damn good job on that, too. Anyway, we said if you really want to look at the moon and moonshots as an inspiration for the fight against cancer, cancer doesn't meet any of those criteria. We don't know the science. It's not a simple problem. You can't check before, was it successful, or after. And costs, you probably do care about the money. So if you really want an inspiration, a space inspiration for how to cure cancer, don't look at the Kennedy administration and the Apollo program. Look at the Obama administration and space policy. For whatever reasons, they and the Trump administration, I think, kind of got it right, which was both administrations have sort of said, oh, we don't sort of care too much about launching all these rockets, so we're going to let a bunch of entrepreneurs fight over how to do it. And right now, at this particular juncture, Elon Musk is the most successful of them. That rocket there, this one, which is a favorite of mine, was not Musk. That was a Paul Allen project. It was Burt Rutan designed it. It was the first private enterprise to send a man into space twice in 2 weeks in the same spaceship. And these are some of the competitive rockets that are going on from the Falcon Heavy and the Blue Origin, which is Jeff Bezos, and these guys are fighting it out. And I got to say, they are. I'm an old space nerd from the '60s, and I was fascinated by it. 15, good. That's just where I wanted to be. And Elon Musk is, I think, for better or worse. I mean, he can't complain. He's getting a lot of government money. So again, for a libertarian Puritan, it's not the answer, but I'm impressed. You got this beautiful rocket off, made the most incredible science fiction landing of 2 boosters simultaneously. They put a cool dummy into space in Elon Musk's personal roadster. Someone asked on Twitter, said, I'm wondering whether Elon Musk just committed the perfect murder. And this is the Dragon, which supposedly next year, a billionaire couple is going to get launched around the moon. And I'll have to say, it's more inspiring than anything I've seen since my childhood in the way of space. And I think sort of this showmanship is quite important in the world of innovation. If you look at the history, anything from the invention of steam power and factories and Henry Ford, whatever, showmanship was part of it, and that's just not, in general, the government's strong point. So I love seeing these private entrepreneurs battling it out. So the Fortress and Frontier, which, did I mention there are copies over here? Yes. It's a 2014 document I wrote, a monograph, in which I sort of talk about these ideas. And we're now at Mercatus, we're building a program really around that document and building on it. So let me start on some of the things, some of these Falcon Heavy kind of things. Entrepreneurs who are changing, go back to that calendar test. How do you make it so that you deliver more health care without cutting out some people's appointments or shortening them or forcing the doctor to work longer? So I always start with this because it's my own personal example. I'll ask, anyone have any idea what this thing is on my phone? Just, you got it. So, I read about this thing, and I gave a talk about it in Arizona 2 years ago to 250 insurance administrators. I said, look, this thing, and I didn't own it then, I had it on a slide. I said, this thing can do an EKG. And what it does is 30 seconds, it'll do an EKG, and has an artificial intelligence component that will determine, is the person in atrial fibrillation or are they in normal sinus rhythm? So I asked 250 insurance administrators if they had ever heard of it. Not one of them, to my knowledge, had ever had. I said, well, you need to ask yourself why you haven't heard of this thing. It's an FDA-approved device, for whatever that's worth. And what this means is that every one of you has AFib patients on your rolls, and every time one of those gets spooked and goes to the ER to get wired up, and the ER says, now you're fine, you're going to write a check for $5,000, a waste. And so, second of all, every time one of your patients is actually having AFib and doesn't go because he thinks he's okay, you may be paying $200,000 the next week for treatment of that guy's stroke. So the question is, why haven't you heard of it? And once you've heard of it, why aren't you handing one of these out for free to everybody who presents with AFib who's one of your enrollees? They only cost $99, and then you don't have to pay anything after that. So I got afterwards, the person who invited me told me about a 38-year-old friend of hers who had AFib, didn't realize she had an episode, keeled over, dropped dead, left children behind, everything else, and said, I was wondering if that little device my friend would still be around. Anyway, I flew home from Arizona, and the next morning I woke up at 6 a.m., and guess what I had? I had AFib. So my wife rushed me over to the ER, and they wired me up and said, sir, you have something called atrial fibrillation. Have you ever heard of this? I said, yeah, I've heard of this. I gave a lecture on it yesterday. So, yep, yeah, I know about it. So anyway, they got me out of it an hour and a half. That afternoon, I was back in the swimming pool doing a mile, so I was fine. I haven't had another episode since. But I've had a couple of times when I thought I was having episodes, or might. So 2 months ago, once I was on this road, and that must have been a busy night on that road, because there weren't that many cars when I was there. And my Fitbit showed I was getting tachycardia, and it was rapidly increasing, and I'm going, oh my God, I'm in the middle of absolutely nowhere, 20 miles from the nearest hospital. I don't even know if I can get a cell signal out here. I pulled into a service station, and there is my Fitbit saying, okay, yeah, it's getting pretty speedy. I pulled the thing out, spent some time doing EKGs, and found I'm okay. And I went home. That's the EKG I did that night when I decided I'm okay. And I said, America's health expenditures in 2016 will now be $5,000 less because I bought this little device. And it didn't waste a doctor's time or the whole ER staff, whatever. And then about 2 months ago, I had a similar thing where I had my wife drive me to an ER. I said, drive me there in case, but just pull in the parking lot across the street and we'll sit there. And I gave myself about 10 EKGs and said, nah, I'm fine. It's just a little sped up, a little tachycardia, don't know why, but doesn't matter. We're going home. And once again, 2017, so I've saved all of you $10,000. Say thank you.
Thank you. Glad you're well.
This is one device. The problem is, with everything I'm going to show you, there are impediments to it. This got through the FDA. The question in my mind is, how many devices like this are there out there that never make it through the FDA or make it out in 15 years rather than a couple of years as it should? This is, well, about 3 years ago, the cheapest workable prosthetic hand that would allow someone to do this. Would have cost about $5,000. That was until a carpenter in South Africa hacked his fingers off with a table saw, sent a picture of his hand to a puppet maker in Washington State, and said, is there anything you could do for me? And the two of them collaborated to build a 3D printed prosthetic hand with open source software so it can be adapted to any size. And the cost of this thing, and I've got one hanging on my wall at my office, this one was probably maybe at most $50. And it's useful. It's not the same as a $5,000 hand. But as a colleague of mine who really made these things go worldwide through his use of social media, he said it's the difference between peanut butter and caviar, and sometimes you're more in the mood for peanut butter than you are for caviar. But what it does mean is that a little girl like this can get a workable prosthetic hand, whereas previously they would have said, no, a child outgrows them every couple months, so it's not financially feasible. So when she's 18, she can get a hand. The other thing, and this is part of the brilliance of entrepreneurship, is finding the little tiny, and it's part of the Elon Musk allure, finding the little tiny things that fascinate people and please people that are just as important as the main workings. The fact that this is a workable hand is important. The fact that it's pink is equally important. The little girl chose the color. She got to design it. It became a prestige item. Instead of the girl with the weird hand that no one wants to sit near in class, she became kind of the rock star. My favorite of these stories was that people would adapt these hands with the open source software in ways that no professional company would have thought of. So one father decided thumbs are really useful, so a second thumb would be even more useful. So he designed a hand with a thumb on either end so his kid would have better grasping power. And by great fortune and grace, the son's name was Luke, so the kid, what was his nickname thereafter? Little Hand Luke. So what are these? Nipples. So this is a company, Tavito Biodevices, in Texas, that is aiming to be the first company to 3D print a human organ. And they've chosen the nipple for breast construction as the first and best to try. Why? Because it's relatively thin. The big problem with 3D printing organs, a liver or heart, whatever, is as you're printing, these layers below start dying before you ever get up here. They've not mastered the vascular system, of how you keep it all living while you're building it. And the nipple being a thin organ, they think we can probably make that one work. So that instead of, in breast reconstruction, instead of using a tattoo or some halfway measure that doesn't particularly satisfy the patient, these are built out of the patient's own cells. There is no rejection problem. Hopefully 25, 30 years from now, if your heart goes, we'll stick it in a few of your bone marrow cells in the printer, use your new heart, bang, no rejection, no need for a donor. It's a long way from that, but we were a long way from Elon Musk too. We're now talking about him sending people to the moon next year, when I honestly didn't think I was ever going to see that again in my life. Watson. So there was a Japanese woman who had leukemia, wasn't responding to treatment. She had been from hospital, doctor to doctor for months, nothing positive. So they called in Watson. They fed her genetic data and her records into Watson, told Watson, go do some reading. Watson went out and read 20 million articles on leukemia, came back and said, she doesn't actually have that kind of leukemia, she has this. You guys have been treating her with the wrong stuff. They switched the treatment, she went home. That process of reading her records in 20 million articles took 10 minutes. The doctors said it would have taken them weeks or months they said we could have done it, but it would have taken a team of doctors weeks or months to actually get through it. This is one of the fascinating cases to me. Anyone ever heard of Narayana Health?
Yeah.
Who? What is it?
Well, they exist in India and in the Cayman Islands.
Yep.
And you can get your care at a fraction of the price.
Yep. So how much is a cabbage in this country? You go up to Cleveland Clinic or whatever, or I'm sure right here would be fine. How much is a bypass? Minimum $100,000. Narayana in India, it's $1,400, and their results are comparable to or better than the best hospitals here. Among other things, they have almost entirely eradicated postoperative infection. How? Because they use Toyota methods. When I hear people saying, well, medicine shouldn't be a business, shouldn't be profits, that's the problem, if we get the profits out, whatever, I say, well, Narayana is a for-profit company and a mostly cash business, and they've somehow gotten the cost of a bypass down to $1,400.
It's actually $800 now.
Is it?
And it's 50.
In India, it's $800. In the Cayman Islands, it's
about 30.
like $20,000.
Yeah, I think it's 30,000 there. I know the 800 figure is Debbie Shetty's aspiration. I didn't know he had made it.
No, latest stuff is he's gotten it.
Why? Because Mother Teresa told him, find a way to bring care to the poor of India. Now, I gave you my I don't care slide. Insurance does matter. If insurance in India paid $100,000 for every bypass, I can pretty well guarantee that there would never have been a $1,400 bypass. 30?
No, yeah, that's the second 15. That would be 30.
Great. I'm doing fine. Here's my Africa slide. I was talking to shit there. So I think a lot of the real innovations are going to come in countries that have been way behind the curve and have a chance to lead. I was talking to her about, she's from Nigeria, and I was in Nigeria before she was, back in the 80s when I had some business to do there. And it was practically impossible to do communications. The manager of bank, which was one of the largest operators in the country, had spent 4 years trying to just get a landline in the manager's apartment. Couldn't. Well, that actually in some ways turns out to be a benefit, because countries like that were way behind the curve on laying out landlines, when cellular came in, they said, who needs landlines? We're all hipsters now. And so cellular became the thing. And now, in many ways, they're leapfrogging over us in e-health, mobile health, in mobile banking, in mobile finance, in mobile everything. Well, one of the other things I mentioned in our chat earlier is these countries also, like India and Guyana, they don't have the luxury of saying, no, we don't need those innovations. We kind of like the way we're already doing things. So about a year and a half ago, Rwanda became the first country on earth to have a nationwide system of drones, aerial drones, flying blood products, plasma and such, and medications to remote clinics, thereby radically cutting down the time. You don't have to pay someone to drive the bad roads of the country, and while your patient is dying, you can fly this thing, and 30 minutes later, whatever you need is parachuted down to the hospital. It's amazing to watch. This year, Tanzania becomes the second country through a company called Zipline. In the United States, we've had precisely one drone delivery of medications. The FAA approved it as a test demo to a pop-up clinic in Southwest Virginia, in a remote area in the Appalachians. And it worked, but basically we can say, we've got pretty good roads, we don't really need that sort of stuff. And so we don't do the innovations. I will add to the prosthetic hands. A lot of the innovation now on that has left the US and is now being done in Colombia, Chile, and Paraguay. Why do you suppose that is? That's really where the cutting edge of 3D printed prosthetics is happening now.
There's no regulations against it.
There's no FDA, and not only that, the countries have basically said, we want you to do this here, we will leave you alone, here's the safe harbor, do this, and we're going to stay out of your way. Telemedicine, another one that I've used. It's a friend of mine, Ian Tong, who's their chief medical officer. I think you met him at my dinner in San Francisco. Ian told a bunch of very skeptical, that a lot of states are very hesitant to allow telemed. And Ian was talking to a bunch of legislators at ALEC. And they were, well, this is kind of modern stuff, and maybe you should come see the doctor. And he told a story about saving a woman's life because he could look at her through the screen and see that he looked at her fingernails and her eyeballs and whatever and said, I think she's severely dehydrated and maybe on the verge of death. Get her out of there and get her to an ER. They saved her. I can add to it that my mother was saved that way. At age 92, my mother, she's kind of a crazy lady. She was sentient and alert just up to the end. She didn't always understand technology, but she liked it. She wasn't ever afraid of it. So she used to do FaceTime a lot with her grandchildren. So my nephew's a doctor, and he was asking, how you doing, Grandma? She said, I'm fine. She said, the only thing that's bothering me is I've got kind of a sore down here on my butt, but I'm going to go see the doctor sometime next week, maybe. And he said, well, tell me about it. And as he was looking at her through the screen, he could see, I don't like the color I'm seeing. I don't like the way she's looking. I don't like the way she's breathing, shallow breath. And he said, Grandma, I hate to ask you this, but you want to show me your wound? My mom, who was a character, said, a very modest sort of Victorian character, she said, well, I'm 92, so what do I care? And she swung the iPad down and showed her butt. And he said, let me call Dad, I'll call you back. And he called my brother and said, I think she's at the beginning stages of something like a MRSA infection. See, I think you need to get her out of that place immediately and get her to a hospital. And indeed she did. Had she waited, she'd have been dead. But through a little amateur telemedicine there, her life was saved and she had another year and a half of good life. There's a lot of fear in medical communities of, well, this could be dangerous. I can imagine situations where something bad happens. I can imagine situations where my mother doesn't get looked at through FaceTime and dies of MRSA. Alternative. Company that allows you to do refraction for eyeglasses at home or at your office, whatever, using your laptop. Some of the, frankly, more conservative states in the union are banning it legally, saying, I know you've had a debate there. And it's sort of, well, and the optometrist putting up barricades saying, we don't really like this thing. Surgery Center of Oklahoma, where you can look online and see precisely what every operation will cost. When I talked to the CEO, Keith Smith, and I mentioned that sometimes it's the guys who claim to be free market who are the worst on this. He said, when I opened this and started doing this transparent pricing, he said, the first guy through my door was some left-winger from a union who said, this is great, this is going to help poor people and whatever, and blah, blah, blah. He said, all the good old conservative doctors in town said, oh, Keith, we just don't do this sort of thing. We've got our ways of doing things or whatever. And so it's not just laws and regulations, it is culture as well. DPC, I'm not going to dwell on it, other than CEO of IORA told me that he had gone to a couple of states and said, how's this? You've got undocumented immigrants. I'll put them on my rolls. I'll build clinics. I'll see them. I will treat them for $1 a day. So $365 a year. And several states said, wow, that would save us hundreds of millions of dollars. But then we're going to treat you as an insurer and regulate you out of business. So I can't do that. And when he actually started, some of the undocumented started paying him out of their pockets for care, the state started harassing him and chasing him and threatening him. Over and over, that's the theme here. So here's a company. If any of you have read, how many of you read the book, The Innovator's Prescription? Well, you should. Clayton Christensen and one of the co-authors, Jason Wong, who was a founder of Lemonade Health. This is a company that there are certain medications, they will argue, you don't actually need to face-to-face see a doctor or even talk simultaneously. So it's something where you log on and say, I need some birth control pills or Rogaine or whatever. And it does the, we getting close? 5 minutes? That's fine. And what they found, and they're all the prescriptions are documented and checked by a physician, but what they've documented in a journal is that a doctor can safely, effectively process 1,000 prescriptions per hour using the system that they've devised, which takes a vast amount, clears up a vast amount on that calendar of doctors who right now are doing things the old way and wasting time. And I know dealing with my own doctor, whom we all adore, and she'll talk. She's great with this stuff, but it's a very time-consuming process for doctors to fill out prescriptions, which a lot of it ought to be an automated process. It's highly automatable. What else do we have? Augmetics. Google Glass allows the doctor to do a checkup Meanwhile, someone viewing through the glass is filling out the EHR in real time. It's finished by the time the doctor is done with the exam. The patient can have a print off as he or she leaves, and the doctor has no follow-up work to do. And my last slide, how's that for timing? One of my favorite quotes from John Cochran at the University of Chicago. What's the biggest thing we could do to bend the cost curve as well as finally tackle the ridiculous inefficiency and consequent low quality of healthcare delivery? Look for every limit on supply of healthcare services, especially entry by new companies, and get rid of it. If Elon Musk wants to get into healthcare, I welcome the guy in. With that, I think
You're
perfect.
spot on.
Now we can do the Q&A.
Absolutely great.
You should at an academic institution.
What's that?
You should at an academic institution, right? Mm-hmm. What are academic institutions doing towards this? And do you think they're in any position to actually innovate? Or just have thought leaders like you?
Institutions? Mm-hmm. Yeah, they have their role. I don't want to denigrate them. They do a lot of great work. A lot of good stuff comes out. But I like to compare with the information technology industry. There are plenty of innovations that came to IT in the last 25 years out of academia. But most of what came out was from obscure, bizarre little places and crazy people in garages. People who work for Facebook and whatever. There was a remarkable development in the early 90s, which, if I were going for a political science degree, I would make this my doctoral dissertation, which is how did Congress and several presidents get completely sensible on IT in the early 90s? What they did was, especially with the internet, bipartisan consensus, which was about to tightly regulate the internet, which was a new and governmentally designed thing at that point, suddenly turned into a bipartisan consensus to say, why don't we step back and let it happen? And rather than, we realize it poses lots of dangers, but why don't we let's see what happens, and when something bad happens, we'll deal with it at that time, rather than anticipating everything in advance. Now, if someone in 1990 had been vehement, and if they had had perfect foresight, they could have said, well, but if we allow this internet and these cell phones to proliferate, people would be able to use them to coordinate airplane attacks on skyscrapers. They'll be able to steal personal identities. They'll be able to dip into people's bank accounts and bankrupt them. They'll be able to screw up American elections. They'll be able to do all sorts of terrible things. They'll be able to invade privacy. And they would have been right on every count. But is there anyone in the room here who says, you're right, why don't we go back to landlines and the Encyclopedia Britannica? They let us take risks, and they're extremely dangerous risks. I will often give this argument. People say, well, you can't compare medicine with IT. It's life and death. And I say, now these things are probably more dangerous than any doctor on earth. These things are controlling airplanes and controlling your bank accounts. How many lives are ruined by some unseemly activity on the internet as opposed to ruined because they get a sickness? And yet Congress and presidents stepped back and said, let's let it happen. Let's see what happens. And what happened was mostly good and mostly wonderful. I wrote an article, again, in the 80s when I was traveling in Sub-Saharan Africa. I had a terrible time communicating back with home. My now wife, I could maybe talk to her for about 2 minutes a week, if that. Now, and one morning, I saw a wonderful Cadillac ad that had 5 innovators, one of whom was a woman in Kenya who had gone from being a hairdresser to being the internet provider for most of East Africa. And so I tweeted, I'm on Twitter if you want to follow, I love doing some Twitter stuff. I tweeted about her. Next thing I saw, she hit like. I hit like, I hit follow, she hit follow, and I immediately started DMing with her. And she and I was in bed, it was 5 a.m. my time. My wife was sleeping next to me, and I was in the dark just typing away, had this conversation, and I said, you know, this is quite remarkable. I said, when I was in Nairobi in 1984, it was practically impossible for me to contact her. I said, yet you and I are sitting here having this incredible conversation, and I wrote about it, and you know, it's not just the ability to have a nice chat. The last 25 years has seen the biggest decrease in abject poverty in world history, and part of it is because if you're in remote areas, you got a cell phone, you can see where the agricultural prices are doing better, and you move your goods there instead of there as you thought you were going to do. And in a million different ways, these things are improving the world. But what it required was these governments to get out of the way.
First of all, I wanted to thank you very much for it was 2.5 whole years ago, maybe you don't remember, but for coming to speak to our Georgetown med school student body.
I love that.
It started a lot of great conversations, and I think I made about 24 people watch your Fortress versus Frontier video. That was really helpful.
That's good stuff.
A two-part question. One, I guess, more advanced policy and current events, and a second, like a practical one for every med student in the room type thing. A lot of us rejoice to see Scott Gottlieb finally, for it to actually go through to him be the head of the FDA. In terms of what he's doing there with biosimilars or prioritizing, approving a second drug for everywhere there's an artificial monopoly on one drug to treat something, or a third where there are only two to increase competition. Do you have any commentary on what he's prioritizing there, how that's going so far, and what with that? And then on the second part, obviously Dr. Josh Umber has spoken to BRI multiple times, and he encourages students who want to get involved in something DPC related with direct primary care to look into ways that they can use GoodRx or other things to start their own in-house pharmacy prescription type programs. For a lot of us who look into that and are immediately intimidated by saying, oh, well, we had to learn this whole medical curriculum over several years. How do we also become a pharmacist overnight and open an in-house pharmacy? What resources have you seen in terms of best practical steps for people to take shortly after graduating med school or while they're finishing up in order to get into that area?
Okay, so Gottlieb appointment was an interesting one. So there were 3 major contenders. One of them was a guy I actually recruited to be a part-time scholar at Mercatus, Joe Golfo, who was in the running, and Scott. And Joe was a guy who wrote a book about how the FDA utterly destroyed him and 2 of his products. And it's a harrowing story. It's called Innovation Breakdown, I think, something like that.
What's his last name?
Gulfo, Gulfo. Joe was shockingly forgiving of the FDA and thought it was reformable. I worked for a guy at Mercatus who was a 27-year veteran who said, it needs to be scrapped and replaced and rebuilt in different ways. Then there's Gottlieb, who was, there's a third one, and I'm forgetting his name, from Silicon Valley. But he was going to be the real radical.
The guy from Peter Thiel's group.
Yeah, I can't remember his name right now. Menk. Anyway. So some of us sort of were sort of emotionally interested in that guy. Gottlieb was probably not as radical in it, but as it was noted, he knew the FDA backwards and forwards and knew Washington, and probably could be the most successful of them at actually pushing whatever he decided to go. So he probably won't go as far on some things as I would like, but he probably knows how to go as far as he wants. So yeah, I mean, I think it's very encouraging. I mean, there are a number of agencies that are doing interesting things in the regulatory front right now. FCC, which is also sort of tied into some of this stuff. So I don't know a whole lot of the specifics of, whenever I read about what Gottlieb is doing, I find it encouraging, and I suspect he'll get a fair amount of what he wants. I'm trying to think of, there's one issue I wrote about recently where I found I was on the opposite side. He was much more hesitant, reticent than I would be. I can't remember what it was. The second issue you asked about, all I can say is I did a master's in health administration back in the 90s. And the most frightening thing I ran across was in one of the law classes when we reviewed the Stark Acts. And we reviewed the conflict of interest legislation and what could send a doctor to jail in prescribing, a doctor who was both being a doctor and running a lab and sending patients and whatever. And I just said I will never become an administrator, simply because there's this tangle, this web of regulations that I found them indecipherable, that you could so easily step over the line and violate the Stark Acts, that I don't know how anyone sleeps at night if they're even thinking of doing that sort of a dual role. Now, I'll have to admit, since I'm not in that situation, I haven't thought about why a doctor would want to run a pharmacy. I'm an economist. I think specialization of labor is a good thing, and probably should have pharmacists, and a doctor probably shouldn't try to learn to be a pharmacist. And in fact, I tend to be one who thinks pharmacists should be given greater powers, power to prescribe medications, because by and large, the pharmacists know more about that stuff than the physicians do. That actually is one of the, in healthcare, you can find some things in Europe that I actually prefer to hear. They don't have an FDA, they have a set of competing private entities that approve drugs, and with a reciprocity agreement. So if I've got a new drug I want, I can look around at all the different private entities and go, I think that one's the one I'm going to go to because she's smart on this particular thing and she gets it done quickly. She's even smarter, but she takes 20 years to get anything done, so I want to go to that one. And this one's not so smart on it, although it does get it fast. So you sort of think of all of them. But they also, a number of those countries also give pharmacists quite significant power to prescribe, which, again, I tend to think specialization of labor is a good thing and more efficient use of labor. I will segue from that to say, if you're wondering how Narayana gets the bypass down to $1,400, it is by using manufacturing techniques that we think of in industrial settings. In their hospitals, when you're getting a bypass, in the initial stages, there may not be any surgeons in the OR. The prepping is being done by nurses and technicians. At the precise moment, in comes a junior surgeon to crack open the chest. At the precise moment that that's ready, in comes a senior surgeon to do the delicate surgery. And so that senior surgeon is not wasting time sitting there twiddling thumbs while the nurses are prepping the patient or someone's cracking open the chest. And as a result, that surgeon will do over his career roughly 8 to 10 times the number of surgeries as the surgeon here will, which means those surgeons also have seen every contingency imaginable because they do so many surgeries. But it's this high level of specialization of labor that gets you there. So my question to you, since I'm ignorant on the topic, is why would you want to be a pharmacist? What else?
Okay.
Anything else?
So any other burning questions?
Just a quick one.
Yeah.
Without a cultural shift, it seems like all the technology, even unleash all the floodgates without any regulation, it doesn't seem like it would be enough for the captive market. Or do you think, let's say, all of a sudden overnight, all the technology is unleashed, right? We still have a consumer that's blinded. They don't know what the cost of healthcare is. There's no transparency. It's not a real market. So what would prevent, insurers or the government from kind of using this technology, hiking up the prices arbitrarily, and just perpetuating the current problem?
Okay, well, let me start. First of all, I don't ever imagine a medical system where there's no regulation. Sometimes I get interviewed on the radio about that. No, I'm not saying that. One reason I don't say it is tactical. I don't want people who are persuadable to suddenly decide I'm a crazy person who doesn't want any regulation. And I know you're not saying that, but part of the problem, one of the reasons we don't have transparency is we have strong tendencies both through government and also private incentives to conglomerate. We have what I sort of consider almost a religious belief in bundled pricing. Well, everything should be bundled. I like bundling. Narayana's hospital does a lot of bundling. Keith does bundling in Oklahoma. And one of the best books I've read that goes into great depth on this is David Goldhill's book, Catastrophic Care. David wrote this, got into writing about healthcare because he's not a healthcare specialist, but his father died unnecessarily of a MRSA infection in a New York City hospital. I think his father was a doctor, and he wondered why would someone like that, with all this knowledge in these fine hospitals, stupidly die of something that was preventable. And he deals, his is the best exposition I've seen on prices. And he was actually in the TV industry, ran a TV network and video gaming. And he said, I spend a great deal of my time bundling things together. I'm going to package these 6 services, and then maybe I'm going to pull this one out and unbundle it and sell it separately. And his competitors are, he's bundling these, I'm going to pull that out and sell it separately. And so a big part of what makes it actually transparent and what makes it work is that you have different people trying different pricing strategies, bundling, unbundling, and as he notes, it's not just in medicine, it's true all across the economy. And yet what we tend to have is people in healthcare who think either everything should be fee-for-service or everything should be bundled. And what you end up with, for instance, we have laws that make it very difficult for specialty hospitals to exist. And what that does is you have a gigantic general hospital which becomes an engine of cross-subsidies so that nothing has a real price. Everything is cross-subsidizing everything else. No price means anything. And no one ever has to price transparently, hence they don't. You really need to ask, why does it work in other industries? What are we doing wrong in healthcare? It's a long, complicated question, but we have basically built a legal, regulatory, and a cultural system, culture including medical societies, that says transparency is a bad thing. One of my other papers, I don't think I brought them, maybe I did, but if not, they're on our website. I wrote a piece with Eric Topol of Scripps, and we wrote kind of a little history of paternalism in medicine. And there's about a 2,500-year tradition in medicine of saying, what we're doing to you is none of your business, so don't ask us these questions. And it's very hard to eradicate something with that long a pedigree. There has never been, in the era of useful medicine, which dates back to the early 20th century, there has never been anything remotely resembling anything you could call free market in medicine. And so when I hear people saying it hasn't been, well, that didn't work, I said, it has never been tried. And so the question is whether we can try it for the first time. And one reason I think we will see it is some of these other countries will try things that we haven't had the courage to do. And they will set examples that ultimately we're going to have to say, why can't we do what Paraguay is doing or India is doing or whatever? Thanks, folks.
Thank you.